Today we're going to understand how to read external review as a service case sheets. ERaaS is designed to provide case management feedback to physicians in a confidential and educational manner and provide physicians with a unique opportunity to quickly review case management and better identify opportunities to improve patient care. Our premise is that many of healthcare cost and quality issues stem from the inability of internal peer review to reliably identify concerns and rapidly improve healthcare. Facilities are rarely able to perform effective peer review for a multitude of reasons: poor identification of patient care concerns, reviewer bias, lack of current knowledge, potential medical staff conflicts, and inability to translate peer review findings into meaningful elimination of errors. A more effective peer review process can eliminate challenges posed by internal review and promote more rapid improvement in patient care. Our goals are to transform peer review from an adversarial process into an educational process which earn physicians educational credits, perform 100% chart review to rapidly identify opportunities for physicians to improve patient care in a confidential, non-threatening environment, and achieve 100% physician participation and substantially reduce potential errors and improve patient care within months, if not weeks. ERaaS works by taking chart data and abstracting and redacting all of the information to create patient case sheets, which are a chronological list of all the pertinent events from admission to discharge. The review is performed by an external reviewer who practices at another facility. Review is performed in a blind manner. The reviewer does not know the managing physician or the managing physician's name and does not know the hospital's name, the hospital location, or patient identifiers. The managing physician does not know the reviewer or the reviewer's name. Review is performed in an objective manner using standard criteria in an open format that permits ready evaluation and promotes open discussion. Review comments are intended to mentor physicians and are protected from discovery through peer review privileges. Physicians are provided a safe environment to review their case management to identify opportunities for improvement, learn from potential errors, and improve patient care. This is a patient case sheet with a blue top header and a list of chronologic events from ER admission to discharge. The header information includes identifying information not disclosed here, such as the medical record number, the chart number, the date of birth, the age, gender, admission and discharge date and times, length of stay, whether or not the patient is deceased, a general case type, diagnoses obtained from the discharge summary, past medical history obtained from the H&P, complications identified during hospitalization, and reviewer comments, which will be discussed a little bit later. There's also an ability to flag a chart for transfusion committee or P&T committee or other departments. The case sheet contains a chronologic list of all of the pertinent events between admission and discharge, including the vital signs, which are color-coded, key laboratory tests, medications, narrative reports, H&P, discharge summary, consultation reports, operative reports, anesthesia information when they went into the OR, when they came out, and all the pertinent information, and at times ECGs or radiologic studies. Mentoring comment feedback is provided to physicians relating to blood products and potentially other services as well. The comments are located in the far right column adjacent to a category critique. All of the information on a given line, in this case the H&P, is linked back to the source document through that icon. By clicking on the icon, we can now see the in this case the H&P, which is fully redacted of all identifiers, to verify or validate any information or to do additional research. Each blood transfusion is evaluated into one of 4 categories. The appropriate category is designated as no exception or green. Only 5 to 10% of transfusions are designated as totally appropriate. That doesn't mean others aren't appropriate, it just means these are so appropriate that there's no question about their employment in this particular instance. And since 50 to 70% of transfusions are probably not beneficial, it's not surprising that only 5 to 10% of transfusions are critiqued as no exception. If there is no start time for a transfusion, that a transfusion is designated as not critiqued. 15 to 25% of transfusions are typically classified as avoid. Our loose definition of an avoidable transfusion is one where the physician in hindsight would likely say, gee, look at that, I guess I shouldn't have done that. So this is not about a 7 versus an 8 gram hemoglobin transfusion trigger. These are about transfusions that I think most people have fairly universal agreement that the transfusion was not beneficial. In 50 to 60% of time, the transfusion is designated as defer. This does not mean that they should have waited to give the unit of blood necessarily. This defer just means that we're not classifying it as totally appropriate, not no exception, or we're not designated as a void. And this is important because it gives physicians a unique opportunity to study their case management in hindsight to determine for themselves, gee, did I really need to give that unit of blood at that moment in time? Was there something else that I could have done instead? Or more importantly, if I'm now faced with a similar situation in the future, will I consider changing what I've been doing for the past several years based upon what I'm learning by looking at these case sheets and earning educational credits? Now, there may be times when a physician feels that they didn't order that unit of blood, and it's important to recognize that we're not looking to pin this onto the physician. This is an educational process. So if you are a hospitalist and this is a hospitalist case, don't worry so much as to whether or not you ordered that unit of blood, but look at the case and see if you can learn something from the case management. In the blue heading, there is a reviewer comment. We do provide critique comments on line items for a given event. However, there is a header for reviewer comments, which is a case for sort of flagging a chart for specialized attention, such as was this patient a candidate for iron studies or earlier iron studies? Is this patient a candidate for IV iron, etc.? Each month there's a listing of the different charts, and there is a referral tab that indicates all of the charts that have flagged reviewer comments. So one can easily go through this and identify the types of problems that are perhaps recurring on a regular basis, and this is a good place to start when looking at case sheets. Finally, we want to encourage everyone to ask questions. And to, if something is not clear, to ask questions. You can begin a dialogue with your colleagues to see if you can learn from these cases, learn to improve patient care and begin that lifelong learning process using this exceptional peer review program. If you do have any questions, there'll be ample opportunities to contact people through links provided in the service. Thank you.